All right. Hello, everyone. Thank you so much for joining us today. Today we have InnovAge, who's a partner of Ask, who is going to present to you some information on heart health. We have Anthony Nappi and Leslie Mader with InnovAge. And with that, I will turn it over to them for introductions and a little overview.
Great. Well, hi, everyone. My name is Leslie Mader, and I work with InnovAge as their strategic account executive for Colorado and now Virginia. Just have to hit the video thing. But anyway, we're very happy to be here with you today. And so Anthony is a very talented clinician. He is not only a registered nurse, but he's a physical therapist. And so I look forward to him giving you some information about heart health. And interwoven into our presentation today, we're going to be telling you a bit about our program and then how we treat folks with heart health issues. So with that, we're going to go through he'll go through the slides for you. And then I'll be piping in on different topics. And before we get started, we're assuming that everyone on this call is a service coordinator. So we're real excited to be with you too. We love serving older adults. So just want to make sure, as Nina had mentioned earlier, if you've got questions, please put them in the chat. We're glad to address those. So go ahead, Anthony, if you want to get started.
Okay, here we go. All right, so as Leslie said, clinically, I'm a physical therapist and a registered nurse. But I would say about the last 15 years of my career, although I still clinically practice in that realm, primarily physical therapy, I really became interested in care management and care coordination, specifically with elders. And so that's kind of, you'll be able to tell that's really where I'm coming from the standpoint of a care manager and who's working at a care management organization, in this situation, a PACE organization. So I'm going to speak with respect to heart health, some basics about heart health, and kind of make that relevant, hopefully, to this group, and also from the standpoint of care management and how to best manage a complicated medical condition, heart disease being one. But as we know, elders often have, in addition to just generalized frailty, many complicated conditions to manage. And so I'll talk about it from that standpoint. So with respect to just a couple quick questions, service coordinators, that's what you all do, I presume? And that's from a housing standpoint, or tell me just a smidge about that so I can kind of make this a little bit more relevant.
Sure. So I can answer that for you if you'd like. So service coordinators work typically in senior affordable housing and are responsible for assisting with facilitating connections between the resident and a service provider to help them age in place.
Okay. And so I presume most of your folks know these residents for some period of time and kind of know their habits, know when someone might be in the hospital, know when someone's at home, know when someone's doing well or doing poorly?
In an ideal world, yes.
Okay, great. All right. All right, let me get this PowerPoint going and I'll share my screen and we'll go from there. Okay. So, like I said, we'll speak briefly about heart health and kind of how that relates to frail elders with complicated medical conditions and how to best address that. And I'll speak mainly from the standpoint of someone who works at a PACE center. And whether or not you're familiar with PACE, I'll start there. Stands for Program of All-Inclusive Care for the Elderly. And that's more of a generic term for the level of care. So a generic term as in the PACE level of care is similar to like a long-term nursing home level of care in terminology, as far as it's a generic term. or you could talk about a short-term acute care hospital, that kind of thing. It's another level of care, PACE is. More specifically, I work for InnovAge PACE. So that's a company who owns some PACE centers, but just to define PACE as more of a generic term. So with respect to heart disease, I would just consider this really just one of the laundry list of complicated medical conditions that folks could have. And we'll just go briefly through a quick definition, a quick heart health quiz. I'll give a few seconds if someone wants to shout out an answer. Otherwise, I'll just talk about the answer briefly and we'll move on. And I'm going to also, Leslie will speak a bit about PACE. And then we're going to go through kind of the level of care PACE compared to the traditional model of healthcare delivery. And also a case study of someone that I personally worked with here. And I'm practiced out of Charlottesville, Virginia, PACE Center in Charlottesville. So heart disease typically involves one of three components. It involves either the blood vessels of the heart, which is what you would typically think of with a classic heart attack. When someone has a heart attack, it's typically, there's a blood vessel that has a small clot in it. And if a surgeon wanted to fix that area, they may bypass, put a vessel around that spot, which is kind of that classic term for bypass surgery. And so heart disease can involve the blood vessels. It could involve the cardiac muscle itself. Typically, I think of pump failure. The heart's a big pump, and there are certain conditions that affect the muscle of the heart and make it ineffective. So the muscle part of the heart could be diseased. Another component of heart failure or of heart disease, or the electrical system. When you hear about people who have an abnormal heart rhythm, like atrial fibrillation, something like that, they might require a pacemaker. That typically indicates that the electrical system, the heart, is involved with the heart disease. And it could be one of these components or all three. Quick quiz. We don't have to belabor these points, but a couple just quick questions. Heart disease and heart failure are the same thing, true or false? The answer is false. So heart failure is a type of heart disease. And that typically refers to that muscular component that I talked about when it comes to heart failure. And we'll talk a little bit more about kind of things that you would see. And I would think of, you getting to know your residents well. And we'll talk about kind of things that you might see related to the heart not working well anymore and what you might observe with residents day to day in the buildings that you serve. As far as warning signs, typically shortness of breath. You might know someone who is typically not on oxygen and maybe requiring more oxygen. Swelling, you may see people with socks that look really tight all of a sudden, that kind of thing. Falls are another type of a warning sign. Basically indicators that the heart's not working well, the pump isn't working well, and blood is not getting to where it needs to be. And so those are typical warning signs that you might see with respect to someone who's progressing along the continuum of heart disease. Seniors with high blood pressure, diabetes, thyroid issues have increased risk of developing heart disease. That is true. These folks have, like I said, typically a long list of medical problems. Many of them contribute to the development of heart disease. And those are three big ones: high blood pressure, diabetes, and thyroid disease. As far as family history, that does play a role. The question number 4, family history is the biggest risk factor for heart disease. And that actually is false. I think of the big 3 contributors to heart disease: inactivity, smoking, and diabetes. This question number 5, I like this one, coming from the standpoint of being a physical therapist. Older adults should rest their hearts as much as possible. That's false. I try to get everyone exercising, and it really is good, even in the context of someone with heart disease. measured exercise is important. So resting their hearts is not something that you would want to do long term. And then finally, aging causes changes in your arteries, which can lead to high blood pressure and other health problems. And yes, that's true. As we age, our blood vessels undergo changes, build up plaque, become a little bit less flexible, and that can lead to further progression of heart disease. And I mentioned some of these, and this is the kind of thing that you could, be on the lookout where you are in your public housing buildings. You get to know people fairly well, I imagine, over the years. And when you're seeing people have more trouble, they're tired, might be walking around holding on to furniture or holding on to the walls and that kind of thing. When you notice that kind of thing, symptoms in people that you know, that could just be kind of an alert, maybe, I'm not sure kind of what outreach you have. Do you have, contact with folks' doctors or ways to streamline them into seeing a practitioner? But that would be, any of these types of things would be kind of an alert to notify a family member or notify some kind of medical team to help them get attention before things progress to the point of hospitalization. And so we'll talk a little bit more generally about PACE. I'll let Leslie comment on a couple slides here, and then we'll kind of integrate kind of overall heart health with care management at the PACE level of care.
Great, thanks, Anthony. So I just wanted to tell you briefly, I'm not sure how many of you are familiar with the PACE model. It's a national model of healthcare that is regulated by the Centers for Medicare and Medicaid. We are the largest provider of PACE in the country. We're in 5 states. We have 17 centers, and we are totally dedicated to serving older adults who are 55 and older. So to be in the PACE program, you need to be 55 and older. You need to live in the zip codes. We're in Virginia and Pennsylvania. So you have to live in our zip codes to be served. You have to meet the skilled nursing level of care criteria, which has to do with your activities of daily living. And there's an assessment, a functional assessment that's done for a person. The goal of the PACE model is to really help older adults age in place, and to really, it's really kind of a skilled nursing home diversion program. It's a nice way to kind of think of it. But the wonderful thing about the PACE model is that we provide complete wraparound services to help stabilize and coordinate all their care. And Anthony, if you could go to the next slide, it'll show our circle of care. And what I really appreciate about this graphic is that you can see that a PACE participant, we call them participants, enrolls in our program, and then we surround them with all of these different kinds of care, starting with transportation to and from our center. So if you can imagine, underneath the roof of one of our buildings would be a medical clinic. We have a rehab gym with endless physical therapy and occupational therapy. We have a dental clinic, and then we have day rooms for people to come and to interact during the day. So this circle really shows you we provide transportation to and from our center and to all of your specialty appointments that you might need medically. And then we also have this expert team of primary care folks and all the other clinicians. We'll show you a slide later about who's on our interdisciplinary team. But each of these folks are dedicated to creating a plan of care for an older adult when they enroll with us. On the bottom left there, you'll see that we provide dental, hearing, vision, and foot care, which are really important services as you age and are very expensive if you pay for them out of pocket. We also provide in-home services, things like meal preparation, bathing, even up a wake-up, kind of a wake-up call or wake up and a tuck-in, we call them, where you can have someone come into your home, medication management. And we also deliver folks medications in the mail. On the top right there, it says recreational activities, and really the core component of the program is a social model. We really address social determinants of health, but we're also a social model for engagement to keep people stimulated, exercising. In our activity rooms, we provide hot meals, hot breakfasts and lunches, And so we have our eyes on folks, and so for us, that's really a preventative care model where we can help keep people out of the hospital and in their apartments. So that's just kind of a high level overview. The main component to remember though is that we become their primary care, and then we coordinate all of their other healthcare. So Anthony.
Are folks here familiar with PACE at all? Okay. So I'll kind of piggyback off of what Leslie said, the kind of the explanation of PACE, and then talk a little bit more with respect to the PACE approach to management of heart disease. And so heart disease would fall under the heading, as far as I'm concerned, as a complicated medical problem that lasts for a long period of time. And really the core components of getting heart disease management right are these right here. Primary care, so regular contact and regular continuity with your primary care provider, physician or nurse practitioner. And typically PACE centers are staffed with both physicians and nurse practitioners. In addition to primary care, referral to specialist care. So typically there's a PACE center, which combines the day center, primary care area, the rehab area and gym, which I'll show you some pictures here in a minute, a recreation, day rooms, nutrition and a dietitian, and medications and that kind of stuff. But it starts with primary care and specialty care as far as kind of the provider or physician level management of heart disease. The all-inclusivity aspect of the PACE level of care includes all your medications, vaccines. There's no real Medicare Part D for medications, and that kind of stuff isn't separated out. It's all within that all-inclusive model. As Leslie said, physical and occupational therapy for exercise to address heart disease and that long-term management of heart problems. Recreation and stress management. And really, I think socialization is here in this box as well. Extremely important for overall lifestyle, helping people succeed in the community, and also contributing to good heart health. And obviously nutrition and weight control. Big factors with respect to management of many complicated medical problems. So this is actually a photo of the PACE Center where I work in Charlottesville, Virginia. It's the primary care center. I would say it kind of toggles back and forth between, I'd say mostly a primary care center routine. You go to see your doctor and that kind of thing when you're at the day center. And then maybe along the spectrum of urgency to kind of a geriatric urgent care center at times. As I mentioned, PACE is all inclusive, covers medications, vaccines, any prescribed over-the-counter medications, no copays or Medicare Part D involved with that kind of stuff. Again, to just contribute to, when we think about elders in the community, sometimes medications kind of fall by the wayside, whether it's an affordability issue, a compliance issue. Oftentimes, when we assess a new potential participant who may enter our program, you go and you do a home visit to see what's going on in the home, and you find, medications just stacked up in bags and that kind of stuff. And you can tell there's not been a history of good, solid compliance with a medication regimen. So that's a big focus with the management of heart disease and generalized elder care. Obviously, rehabilitation and fitness is an important component of long-term management of heart disease. We have physical and occupational therapists. We manage, acute problems. Say someone has a heart condition that's new or suddenly severe, and they're hospitalized for a little while. They can come back to the PACE Center and get kind of a round of cardiopulmonary rehabilitation. And then typically that would progress to, it doesn't just stop and say, oh, we're not going to exercise anymore. That would typically to progress to something that we call like a functional maintenance program, where people come in and they do their regular exercises and it becomes a routine and a long-term practice where where people have the opportunity to exercise when they come to the PACE Center.
We have that too.
I'm sorry? Okay. Again, another component with respect to PACE and long-term management of complicated medical conditions and heart disease, recreation, stress management, socialization, all contribute to solid heart health over the long term. As Leslie mentioned, wraparound services, and these are the kind of things that, if you were to look in the textbook and look up what's good for heart disease, you wouldn't come up with transportation. But when I think about, in the past, I remember my father was sick at some point in time, and he was at University of Virginia getting care. And getting him to and from appointments, if he had to go to appointments or if I had to drive him to appointments, that's tough. And you approach a big university hospital, it's like a maze trying to get through, and it's stressful. But if a care management organization such as a PACE center can take things off the plate of the patient or the caregiver, that's big. And that also is the long-term stress management and facilitation of care. And I'm sure it contributes to overall health and more specifically heart health. As Leslie mentioned, in-home care, we all, as clinicians, have the agility to see participants, whether they're in their home, in the PACE center. We also provide, as Leslie said, kind of get started for the day. Might have a home health aide go out and see someone, get them ready for the day to come into the PACE center, and again, facilitate their care in order for them to get the right exercise and see the primary care physician and get their medications, all contributing to that long-term management of heart disease. Caregiver support, I alluded to this a little bit with respect to transportation, but it doesn't work without a partnership between the care management organization, the participant, and the caregivers. And if there's ways to alleviate caregiver burden, we seek solutions out to help keep people in their home longer. And we know that's better for their long-term management of their medical conditions. And it's better for them overall to stay out of the, Leslie mentioned a nursing home diversion program. It's also important to keep people out of the hospital in general. So there's many risks associated with that, which I'll comment on here in a few slides, or one slide, I'll comment on it. So oftentimes when I speak about PACE and when I speak about long-term management of complicated health conditions, I'll compare like the traditional model of healthcare to what a care management organization, such as a PACE organization, looks like. And I always say we see this from wherever we sit with this syndrome that I'll talk about. And I'm sure you do with respect to your residents whom you end up knowing fairly well over a long period of time. You know who goes to the hospital a lot. You know who gets home from the hospital and then goes right back to the hospital, I imagine, if you know these people for a while. And I can picture some of the folks I know who are PACE participants, but also living in public housing, and I'm back and forth in between both worlds. And you see this syndrome going on, this healthcare syndrome, where someone is on their own, doing fairly well. Let's say Mrs. Smith's on her own. She's doing fairly well, but she has heart disease. And the issue with her heart is that should she deviate from a strict diet, she may retain some fluid, have a tough time breathing, and end up having to go to the emergency department. So Mrs. Smith is that on my own block right there. She eats a can of chunky soup. It's got about a week's worth of sodium in it. She can't breathe anymore that night, and she goes to the emergency department after calling 911. After being assessed in the emergency department, most folks in there don't know her. She's sent to the acute floor of the hospital. Again, most folks don't know her there. She gets treated there. She goes to what I would generically term the post-acute arena, which is typically a nursing facility to get a little stronger before she goes home. Most folks don't know her there. Then she gets handed back home to a home health organization who sees her for a little while in her home. she starts to go to church and get her hair done. And then the home health says, well, she's not homebound any longer, so we have to discontinue her care. And then she's on her own again to do it all over again. And so the problem with this is, one, like I said, oftentimes these handoffs of care are very vulnerable points for elders where mistakes can happen, medication errors, that kind of thing. And then when someone travels through the healthcare system like this, unassisted, these trips are fraught with risk. Their sleep is disturbed. There's chances of delirium. They can pick up an infection that they didn't have along the way, have a fall and an injury along the way. So these trips through the system, these unguided trips, are fraught with risk for elders and folks with complicated medical conditions such as heart disease. So this is a real participant whom I worked with for some years. She's passed away since then, but she came into the program here. She lived alone. Among her biggest diagnoses was heart disease, specifically congestive heart failure, which is more a disease of the muscle of the heart and a pump failure, really. So for the 14 months leading up to when she enrolled in a care management organization in PACE, she was at the emergency department 59 times from about an hour away. So 59 rides in an ambulance over the course of 14 months, primarily for congestive heart failure. I'm going to take another comparison of the PACE level of care and explain that compared to that traditional model that I just had up there. So the center, the blue PACE area is basically like the happy place. That's the PACE center where people come and they get their socialization. Everything's in one. They're getting their medications. They see their physician or nurse practitioner if they have to. They come to me and they exercise in the gym. All that kind of stuff. Get a good meal, a nutritious, low sodium meal. Good solid stuff with an interdisciplinary team of people who know this elder for a long period of time. So good continuity. Nevertheless, we know elders with complicated medical problems and heart disease, at some point, care will escalate, right? And so they might go to the ED up in the upper left there, the emergency department. But they don't go lost to the emergency department. They're in that overlapped area where our nurse care manager is calling the emergency department care manager and coordinating the care of our elders as they pass through the emergency department. So that their transitions are guided, that we can call and say, Mr. Such and so, he's had dementia for 5 years, and what you're seeing is his baseline. So there's no need to expose him to an unnecessary test to try to determine the reason that he's confused. We know he's confused, and we don't need to subject him to risk of multiple unnecessary tests, because typically the emergency department staff would be learning Mr. Smith for the first time, right? So we can kind of streamline his way through. He might go to the acute care floor after that. And again, he would be in the shaded area, not lost, and we would help streamline him through. And we would even go on site and see Mr. Smith in the hospital bed, talk to the staff. I've done a lot of this work over the years at this organization where I'll go and get into rounds at the hospital and help direct their care and say, well, the way he looks to me as someone who's known him for a long time, he looks like we could bring him home and support him and come into the PACE center. We might bulk up our home care, bulk up his PACE center attendance, but we can manage him here and then avoid that post-acute scenario. So basically streamline his care, get him home sooner and safer, and avoid another step through the healthcare system. You're avoiding all those other handoffs of care and those risk points for elders. So that's just kind of a oversimplified view of how a PACE care management organization would work for someone with heart disease versus that traditional on my own kind of model where there is no real solid continuity and coordination. The same participant I talked about 59 times to the hospital in 14 months went 3 times for the 12 months after she joined the PACE organization. So again, it was just that wraparound care that was really effective. And what I find comforting as a clinician in care management is that something can be both, the most important part is good for the patient or participant, and also fiscally responsible and more fiscally wise for the organization providing healthcare. Questions or anything? So depending where you are, so as Leslie said, PACE centers are driven by zip codes. And so a PACE center may be responsible for, I don't know, 14 or 15 surrounding zip codes, depending on the population density. So what if there is no PACE? Again, to try to keep this somewhat generic, there are many models of care management. And so I think if you were in an area where there wasn't a PACE center, you'd have to really just kind of seek out, elder care management. There's Pennsylvania Department of Aging. Locally, where I am in Charlottesville, Virginia, is an organization called Jefferson Area Board of Aging, all with kind of care managers and an approach that is similar to the PACE approach, but maybe kind of without walls, but still some care management to help streamline elder care and management of complicated medical conditions like heart disease. Leslie, you have anything more to add there? Or?
No, I just suggested in the chat, if you, I know in Pennsylvania and Philadelphia that there are a couple PACE, there's our PACE program, and then someone else mentioned Mercy Life. We call ours Life as well, InnovAge Life. And so if you're interested in knowing if we're located in your area, you can reach out to me, or you can also go online. There's it's the National PACE Association, and it's called, you just go to NPA online, and you can pop in a zip code and they'll tell you if there's a PACE program. So, but we are in Philadelphia, Pennsylvania, California, New Mexico, and Colorado. So yeah, does anyone have any questions for Anthony?
Thank you all for your time.
I have a question.
Okay.
And my question is, I have referred people to, not your particular program, but talk to family members about the program we have a little bit closer to us. And the amount of assistance in the home wasn't great enough for it to be feasible for this particular person. Do you have a general amount of hours in the home that you can support someone?
So that's a good question. That's a great PACE question. And nationally, from the standpoint of home care and guidelines with respect to the PACE level of care, home care is considered, it's considered task-based. So really what happens is at the time of assessment, a nurse would go to meet with a patient and caregiver, or participant and caregiver, and go over kind of what tasks need to be completed in the home. And the amount and duration of home care is based on the completion of those tasks. So maybe it's laundry, meal prep, and helping someone get dressed or that kind of thing, or bathe. That might take 2 hours. And so that would be the duration that they determine would be needed. Now, PACE traditionally doesn't do kind of like long sitting services with folks and companion kind of stuff. It's mostly, it is task-based. So there are other programs that do kind of more of a long-term, maybe long day companionship with participants. In Virginia, there's a program through Medicaid called EDCD waiver. It's elderly and disabled and consumer-driven waiver, where an aide would stay for maybe 8 hours a day kind of thing and support someone in their home. Since PACE is more of a wraparound service that includes a day center as well, home care is typically task-based, and that longer term day would be managed in the day center. So they would, maybe a home health aide would go to the home, get someone ready to come to PACE, and then rather than sit at the home all day with someone, we would transport them to the day center, and they would get their support and care at the day center while hopefully the caregiver has a little bit of a break and kind of alleviate that burden with the caregiver. And so, yeah, that longer term support would occur in the day center itself.
Thank you.
You're welcome. Any other questions?
There was one more in the chat about, do you have to have Medicaid to get the PACE program?
Thank you. I realized after I spoke that I didn't really talk about that. So I apologize. That the way that CMS has set it up is someone pays for our program through Medicare and Medicaid combined, or if they don't have enough hours for Medicare and they're over 65, it would just be Medicaid. So it's, we call them dual eligible folks, and we help people get onto Medicaid if they're not already, or if they need to transition. There's actually a type of Medicaid called long-term care PACE. So we assist them with all that paperwork for enrollment. And you can pay for it out of pocket, but it's quite expensive.
Right, are there any other questions? It looks like another one came in through the chat. How do you decide that PACE is no longer a good fit if someone's health is deteriorated?
Well, ideally, PACE is a type of a service where we would take care of someone through enrollment, from enrollment all the way through their deaths, and provide end-of-life care at the same time. So people, we expect, and it's a normal process for people to decline medically. That's normal. And so eventually someone may get to the point where they can no longer live at home because they're either functionally unable to do it, or they require too many medical interventions. And so PACE organizations will have contracts with nursing facilities and hospitals, but and assisted living facilities, where if someone needed 24/7 care, then we could place them in a contracted facility, but still be their provider of care, still potentially bring them into the PACE center, still provide all their medications, still do all the normal care that we would do, but we would have to partner with someone with a facility in the community to provide the extra to get to 24/7 really. So then when people progress even further, our staff is trained in end-of-life care. And so we can provide the appropriate end-of-life care in either someone's home or in a facility if we need to. So ideally, someone enrolls in PACE and stays for life. Someone can choose to leave PACE as well. Obviously, if they want, they can disenroll. But typically, we try to keep folks and wraparound care for the duration of their lifespan.
And one thing about enrollment is that we enroll at the first of the month. So it's different than other Medicare plans where you have that enrollment period in late fall, first part of the year. You can enroll at the first of the month. And if someone is with us and they decide, you know what, I think I'd like to transition back to a different primary care and different medical services, then we can disenroll someone at the end of the month.
All right, any other questions? All right, so for those of you who may think of questions later, you all can reach out to either Anthony or Leslie. Their information is on the screen. Leslie also put her email in the chat. I will send copies of the PowerPoint out to all the registrants. And then, as I said earlier, video will be available on our YouTube channel in the coming days. So keep an eye out for that. And thank you, Leslie and Anthony, for your time. We really appreciate it. And
Thank you.
for the rest of you, have a wonderful day.
Yeah, thank you. Appreciate
Thank you.
together.
Take care.
Bye-bye.